managing these patients of obesity need everybody's help. That is, a physician, the endocrinologist, all specialties are needed. And not only this paraclinical, non-clinical help is also needed. So initially, what we think of obesity is of the disease of affluent class, but it's not like that. Because of the development of the agricultural sector, ready-made available food, the changing lifestyle means nightlife parties and ready-made foods, packed foods, junk foods. And because of that, the obesity is increasing, not only increasing the burden on themselves, himself or herself, but it's a burden on healthcare system also. So obesity is nothing but the BMI more than 30. But what we are mainly concerned about the morbid obese and super obese, where the BMI is more than 40 or 50 respectively. And why we are more concerned about this? Because the perioperative morbidity and mortality is very high. It's almost double in obese patients. And if it is associated with the end organ damage, like cardiac failure or respiratory failure, the mortality is almost more than 10%. It's a huge mortality. And that is because of the pathophysiological changes happened in obesity and associated comorbidities. So we are going to see the obesity-related medical complications, their evaluation, and the anesthesia management. So as you know that the fat is there all over, in the chest, outside the chest, in the abdomen, and compressing the lung from all sides. So all the volumes and capacities of the lungs are reduced. And mainly the functional residual capacity, that is the amount of air which is removed, the gases exchange. And if that is reduced, the overall gases exchange is reduced. And that FRC is reduced further when patient lies down. And again, when in the tunnel position, when they do the lithotomy position, in that condition, again, lungs get compressed from outside and it becomes restricted lungs. So in one hand, there is a restricted lungs, and on the other hand, there is increased oxygen demand and CO2 excretion demand because of the increased weight of the patient, the increased metabolism of the patient. So these patients are more prone for hypoxia and hypercarbia. Not only this, but cardiovascular system is also get affected. With each increase in the 1 kg of fat, there is increase of almost 50 to 70 ml of blood needed to be increased to meet the metabolism of that fat. And because of that, there is increased stroke volume and cardiac output. So the left ventricular wall stress increased. It becomes a left ventricular enlargement. So because of the volume load, there is eccentric left ventricular hypertrophy. And because of the pressure overload, there will be left ventricular concentric hypertrophy. And that may lead to the left ventricular systolic and diastolic failure. And if on the top of that, if it is associated with the hypertension and IHD, as these patients are more prone for the IHD, the left ventricular failure can happen. On the other hand, because of the hypoxia and hypercarbia, there is pulmonary hypertension chances are very high. There increases pulmonary hypertension, increases with the increasing the obesity and weight, and that leads to the right ventricular increase in the afterload and may lead to a right ventricular failure. So these patients are more prone for the biventricular failure. And on the top of that, there is a reduction in the central respiratory drive. So whenever you give sedation, the upper airway tends to collapse and there is a central depression. And these patients are not responsive to the hypercapnia. And small alveoli, even though tend to collapse, the upper airway collapse is also seen because of the fat overall in the or in and around the trachea, in the pharynx, and the cheeks, and like that. So in nutshell, in one hand there is a difficult airway, on the other hand there is a respiratory mechanics are compromised. So these patients are more from desaturation. And on the other hand, the labile hemodynamics are there because these patients are more prone for the biventricular failure. So an anesthesiologist are more concerned about the hemodynamics and the oxygen, and both are at jeopardy. Regarding the GIT, these patients are at risk of aspiration because of the delayed gastric emptying. The metabolism of the drug is altered because of the fatty liver, and the volume of distribution of the drug is increased. And the skin blood flow is reduced, so the subcutaneous tissue perfusion is reduced. So the drug which we give to the subcutaneously may not get absorbed well, like what we give the low molecular weight heparin. And these patients are more prone for the thromboembolism because as it is these patients are a pro-inflammatory state. So the more the increase in the fat inside the body, the more is the inflammatory condition, because they releases the various interleukins and various inflammatory products, and the endothelium is also get damaged. So these patients are more prone for the vascular thrombosis, either coronary or peripheral. So these patients are more prone for IHD and thromboembolism, pulmonary embolism, like that. And if associated hypoxia and hypotension is there, so we have to be very much careful about the post-operative pulmonary embolism. And if you give on the top of that the subcutaneous heparin, and if they did not get absorbed, so chances of PE are very high. So we have to assess first the risk if these patients come to you for various surgery, and not only to explain the risk to the patient, but to optimize this patient and for the better planning. So we have to assess the functional capacity of the patient. If he could not able to do his household work, that means his metabolic equivalent is less than 4, and we have to further evaluate this patient. Now these patients are more for the obstructive upper airway because of the collapse of upper airway, and this can be very well judged with this score of stop bang. That means as the history of snoring, and because of that there is a daytime somnolence and observed apnea, and if blood pressure is high, that is stop. And bang means high BMI, age more than 50, male gender is there, and the neck circumference more than 40. If more these elements, more the chances of patient going into the obstructive sleep apnea in perioperative period. And why we are more worried about this? Because there is as these factors increases, they are more prone for the hypoxia because of the diminished oxygen reserve. They are very sensitive to the sedation. A small sedation may lead to the upper airway collapse, failure to extubate, and failure to ambulate. So we have to be very much careful about this OSA risk. We have to assess the airway, because any obese patient should be considered as a difficult airway. So the clinical assessment is as usual, very simple airway risk index, that is SARI. We have to assess the mouth opening if it is less than 4 centimeter, the thyrometric distance less than 6 centimeter, more the multiple gradings 4, 5, and if the reduced neck movement is reduced, or the prognath if it is reduced, and weight more than 110, and history of difficult ventilation. So these patients are considered to be high risk for the either bag mask ventilation or with the intubation. So screen these patients. And if you cannot able to see this with the clinical, sometimes it is very difficult to assess clinically. So nowadays, very great tool is available with us is the sonography. Put the probe in patients on the in front of neck and assess the difficulty in the airway, and we have to mark the cricothyroid membrane if in emergency for the emergency airway access. So if the distance from the skin to the epiglottis, if it is more than 2.5, and the tongue base thickness, if it is more than 6, it is supposed to be a difficult either bag mask ventilation, or putting a supraglottic airway, or the putting a tube inside the trachea, or doing the emergency cricothyroid. Everybody is, all these factors will lead to a difficult airway. And we have to mark the cricothyroid membrane, because if emergency, we have to do the cricothyroidotomy. And there are two techniques. One is longitudinal technique. So we have to put the probe longitudinally in front of neck, and we can see the string of pulse. And in between thyroid and cricoid, we have to mark it. And there is a transverse technique. There is a TACA technique. That means a thyroid air, cricoid air. We have to slide the probe transversely, and we have to mark the cricothyroid membrane. So we have to assess the pulmonary complications. If how much there is a chance of pulmonary complication in the post-operative period is by assessing bedside. If patient could not able to breath hold for 10-15 seconds also, that means his vital capacity is less than 1.5 to 2 liters. And if it is like that, we have to do the PFT. And in PFT, if even is less than 1 liter, we have to advise the ABG. And in on ABG, if there is a hypoxia without any hypercarbia, that means these patients require only oxygen in the post-operative period after major surgery. But if it is associated with the hypoxia and hypercarbia, and if the FEV1 and FVC is less than 40%, these patients require post-op ventilation, very high chance of requiring post-op ventilation and associated complications, and mortality may be more than 10%. These patients are, as I have already told you, these patients are more prone for a biventricular failure. So we have to assess the cardiac risk. So risk is of if the patient of having a history of IHD or heart failure or cerebrovascular extents, and if patients are posted for major surgery, and also associated with the diabetic requiring insulin or requiring creatinine or creatinine more than 2, more these scores, more there are chances of patients going to the major cardiac events in a perioperative period. And how to assess this? Assessing the ECG, 2D echo, and stress test. But the problem with the ECG is that there is a low voltage ECG you will get, but we can see the arrhythmias. Many patients are having arrhythmias, supraventricular tachycardias, and we don't get by in clinical with the clinical assessment. So you can very well pick up the people in arrhythmias, but there is low voltage over there. Problem with the 2D echo is that the window we get is very problematic. We cannot get the clear window with the 2D echo, and we cannot assess exactly the biventricular function and pulmonary hypertension with this. So it is better to do the TE to assess. And stress test also, they cannot able to do much, the super obese patients. So for that, the best way the assessment of the cardiac is done by the transesophageal echocardiography, and also we can do the dobutamine stress test with the TE. And after assessing all these factors, we have to grade these patients at the end. So if the BMI in the ASA, there is very clear-cut guidelines they have mentioned in the ASA grade 2 if the BMI is less than 40 and more than 30. If the BMI is more than 40, it is a grade 3. And if it is associated with the comorbidity, with the BMI more than 40, comorbidity means the actually one system is in failure, that is cardiac failure, respiratory failure, like that, then it comes in grade 4 and having mortality more than 10%. So this risk assessment is not only for the grading, but we have to prehabilitate the patient. That means we have to optimize the patient before posting the patient to the surgery. So we have to enhance the preoperative functional capacity of the patients. So preparing the patient for the stress of surgery and anesthesia, so that the post-operative mortality is reduced, is with the help of controlling the various comorbidities, that is controlling the hypertension, diabetes, thyroid should be under control. We have to control the pulmonary status, that is stop smoking, incentive spirometry, nebulization. And if patient is on a preoperative CPAP or BiPAP, ask patient to bring that the CPAP BiPAP to the home with the hospital and continue this CPAP or BiPAP throughout the hospital stay, and that will definitely improve the respiratory mechanics, prevention of the atelectasis in a perioperative period. And for this bariatric surgery, if possible, ask them to reduce the weight, need to give the nutritional support or aerobic exercise. These patients are very much psychologically depressed and need a psychological assistance also. So overall, it is a multidisciplinary and multimodal approach is needed for the pre-op optimization of this patient. And these patients, if they are posted for various types of surgeries, the anesthesia choice is regional anesthesia over the general anesthesia. And whatever may be the anesthesia you give, some may insist you this is very small procedure, very close reduction. I will do DNC within a minute. Do not do any shortcuts, because many mishaps happen with the small procedures and immunosuppressed patients. So we have to take the history in detail, do the examination, give time to the patient, because even auscultating this patient may be difficult. You cannot able to hear the sounds properly. Pedal edema, you cannot able to judge. Even a measurement of the BP is may not be correct. You have to take the correct BP curve to that patient. So give time for the history examination and risk stratification and optimize accordingly. Continue antihypertensive agents, omit the OH and ASA. 3 important prophylaxis we have to do in a pre-operative period is the aspiration prophylaxis. We have to keeping the NBM for a prolonged period of time and give the metoclopramide to increase the gastric emptying rate. We have to give the antibiotic prophylaxis as these patients are more prone for the infection. DVT prophylaxis must. If patients don't have a DVT pump, many patients have their stockings and like that, ask them with them and put the DVT pump in preoperative room only. And difficulty in putting the central line and peripheral line is also the use of sonography machines or vein locator is also there to locate the vein and put the IV. If at all the patient is hemodynamics are not okay, or if the patient is having a supramajor surgery, and if you cannot able to find out the vein, put the central line. And for this, very much needed is a bigger OT table, bigger chair, bigger shifter, bigger OT mob, because shifting to this patient and putting this patient on the OT table may not be that easy. And if you don't have the bigger OT table, join the 2 OT tables and operate simultaneously. Yeah, very much important. And do not give any sedation in the perioperative period. or best glycopyrrolate you can give. And the most important is you need a good assistant, or two anesthesiologists are very much needed to manage these super obese patients. This is very important criterion for the preparation. Along with the routine monitoring, we have to monitor the temperaure in output. ETCO2 is must, and the adequate size BP curve should be there to monitor. If it is not possible, the bigger size curve is there, or sometimes there is a burn or like that, or if there is a supramajor or major surgery there, put the invasive blood pressure, put the line in the radius of femoral for the invasive blood pressure monitoring. And if there is a cardiac issue there, and if peripheral IV line you are not able to, you feel that it's not able to maintain throughout the perioperative period, put the central line. Even though I have already told you, even though the surgery is small, the anesthesia to such patients is never a short G or like that. So usually we face such problem for a small procedures and in a NORA conditions, that means the CT, MRI, cath lab, endoscopy conditions, because these patients are more prone for the upper airway collapse. And if you give something to the patients, and even though surgeon says that I will do in a minute, it's not possible, because it is difficult for them also to do the surgery or small procedure within a very short period of time. And if you give something to that patient, there is upper airway collapse, efforts introduce, patients start to desaturate, and the position is like that. They ask to give the more head low position, and if the big thighs are compressing again on the abdomen for the DNC patients, the patient collapse. The small procedure, in a small sedation, can lead to a big chaos. So do not give a sedation without any preparation. So for giving a sedation, we have to prepare, and prepare in such a way that the oxygenation should be maintained properly and proper position should be given. So for the oxygenation, 2-3 important tools are there to maintain the oxygenation. The nasopharyngeal airway that bypasses the upper airway resistance and give the oxygen directly in front of the glottis. And in one hand, you can give the oxygen, and other hand, you can monitor the ETCO2 and the respiratory parameters through this nasopharyngeal airway. And high flow nasal oxygenation. This is very a good tool. I like very much. Around 60 to 70 liters of oxygen can be given through the nasal prongs, which is humidified, and temperature also maintained with body temperature. And what will cause it bypasses the upper airway resistance and replaces the upper airway with 100% oxygen. So when your patient takes a neck breath, he will get a 100% oxygen, and also helps in to manage the oxygenation in apnea also, because with the it creates some PEEP, and with this PEEP, with the gaseous exchange at the alveoli, the oxygen goes from the alveoli to the blood very rapidly compared to the carbon dioxide which is excreted from the blood to the alveoli. So the negative pressure is created, which sucks the upper 100% oxygen, and in this the oxygenation is maintained, and hypoxia can be prevented, and the apnea period is increased almost up to 10-15 minutes even in obese patients. So this tool is very much important, and those patients who are already on a CPAP or BiPAP, ask them to bring this machine, or ask this machine and keep it in the OT or in any NORA area, and put it on the patient, start this CPAP or BiPAP, and then give the sedation. And the proper positioning should be maintained. The head up position, 20-25% position is maintained to improve the mechanics. And also we can do good laryngoscopy in this situation. So, and after that, if you want to give sedation, give that avoid benzodiazepine, and you can titrate the doses of the phentermine, dexmedetomidine, ketamine, or Dexkit is a better choice. And this method is not only for the sedation. This is useful for the pre-oxygen during intubation. Immediately after extubation, the same procedure is done. So if given a choice, I already told you, the regional is better over the general anesthesia. Whenever possible, sole regional anesthesia technique is preferred. But if it's not possible, it should be combined with the general anesthesia, which reduces the requirement of the general anesthetics and basically the opioid. So regional anesthesia, it's not that easy because of the palpation of the landmark is difficult, and the difficulty with the position. In this figure, you can see the anterior superior iliac spine cannot able to palpate, but just putting a sonography probe on it, you can able to see very easily the all the landmarks and the nerves very easily. So if you give a blindly, there are very high chance of complications and block failure, but that can be reduced very well with the using of the sonography. Nowadays, use of sonography and putting a needle under sonography nerve is a new era of anesthesia. So everybody should be well versed with the sonography. Now the neuroaxial block is also very difficult, and with the increasing the BMI, the increasing the depth of the epidural and spinal space from the skin. So a longer needle is needed, and for marking of the spinous process, you can use the sonography machine, and then you can give the drug. So how much drug should be given? It's almost 20 to 25% lesser drug is needed because of the obesity. There is intra-abdominal pressure increase, and there is a epidural blood vessels, they are engorged and reduces the space of the epidural and spine both. So even though this is right with the non-pregnant patients, but in pregnant patients, not that much of a reduction of the dose is required. In one paper, I've not mentioned here, they mentioned that either equivalent or almost you can reduce maximum up to 10% reduction of the dose is needed. In non-pregnant patients, we can reduce up to 20 to 25% for the spinal and epidural doses and add the adjuvants of your choice. And now regarding the general anesthesia, follow the all gold 10 golden rules. See the position of the patient's pre-oxygenation and drug dose calculation is must and should be done before in hand, and then induce the patients with the keeping in plan ABCD ready. And in difficult airway cart, all sizes of the laryngoscope, their blades, video laryngoscope is preferred and that should be kept ready. All sizes of the endotracheal tubes, fiber optic bronchoscope is if feel it's a difficult airway, and phone front of neck axis and cricotherectomy set should be kept ready. And this is a ramp position is given, and either it is completely head up or with the ramp position is given as shown in figure. And for that, different pillows and the position of the operation table is adjusted accordingly, and the air of pinna should be in the line with the sternum level. And regarding the pre-oxygenation, you can do just now I told you, if patients on BiPAP, continue. If you have nasal bronchs, the high flow nasal cannula is preferred, and on the top of that, put the oxygen mask and keep the APL wall up to 10-12, so that patient will oxygenated with the PEEP, so that the atelectasis is during induction is prevented. And continue this nasal oxygen and high flow nasal oxygen during intubation, so that will increases the safe apnea period. And rapid sequence induction is done, and video laryngoscope is preferred. That will help to see the larynx from closely, and not only to the operating anesthesiologist, but assistant anesthesiologist and other person also can see the larynx, and accordingly they can manipulate, and if at all they can do an additional help to the patients. The first attempt is the best attempt, and if at all if it is needed, do not try to keep on attempting. If you are not able to do the intubation, just do the bag mask ventilation again, come back and came out of the situation. If at all needed, put the supraglottic airway. But if you encounter cannot intubate, cannot ventilate situation, go for the FONA, that is scalpel bogey tube technique, preferred over the needle cricotherectomy set. But you have to keep these two set, scalpel bogey tube and the needle cricotherectomy set, well in your crash trolley before actually going the induction. So induction is done with the fentanyl, propofol, scopolamine, atracoram, dexmedetomidine, no issue with that. But the most important question is to how to calculate these drug doses, because there are various drugs having a more lipophilic or more hydrophilic. Their volume of distribution is different, their clearance is different. So I have studied this and I have formulated one thing. Only 4 things are done with the total body weight. That is propofol infusion, scopolamine, dexmedetomidine, and newstegment. And apart from that, all drugs should be done calculated with the lean body mass. What is lean body mass? It's actually ideal body weight. You know that if it is height minus 100 or 105 male and female, what we get is the ideal body weight. Lean body weight is nothing but it's divide of fat. That is almost 10% big more than the ideal body weight. And adjusted body weight, that means the metabolically active body tissues. So in between ideal body mass, and this is around 20 to 25% more to the ideal body weight. So the lean body mass is considered for the rest of the calculation. So propofol bolus we give during the induction of anesthesia is calculated as per the lean body weight, because the volume, the action wears off with the distribution. And if you give propofol in infusion, the propofol will go into the fat. So we have to consider the total body weight. In that way, we have to calculate. the opioids and all the muscle relaxation should be calculated with the lean body mass. And the most important is that this is an initial bolus doses. We have to calculate it, titrate accordingly as per the body's reaction and response to the drug. And inhalation maintenance is with the desflurane. As you know, that this is the drug of choice in obese patient, as this drug doesn't go into the fat, and there is a rapid recovery and a return of airway very quickly. But if there is a cardiac situation is there, so suppose cardiac condition is there, so diastolic dysfunction, grade 3, in that situation, CO is preferred and nitrous oxide is not used. Even the TIVA is preferred, but should be opioid free as much as possible. So after induction, during the position, these patients are more prone to sleep because of the weight. So should be strapped before proceeding to the surgery. They are well padded because these patients are more prone for the nerve injury and pressure source. As there is a, and while giving the nerve blocks, we have to document it, the peripheral neuropathy, for the medical legal purposes. DVT pump must be applied. Fluid warmer is, if possible, should be given fluids with the warm fluids given, because these patients are prone for the hypothermia. And if the position is given a steep head low, 10 lumbar, the chances of endobronchial intubations are there. So auscultation before starting procedure should be done and the tube is adjusted accordingly. And if suppose chance of hypotensions are there, so the hydration it should be adequate before giving position, and we have to keep the vasopressin inotrope ready to tackle such situation. Now, the another important concern is how to ventilate these the restricted lungs of these morbid obese patients, because these patients are more prone for the barotrauma and volutrauma. So ventilatory mode is preferred is the pressure control over the volume control mode, but we have to keep watch on the how much is the volume going, because that is will be labile. And if in your ventilator, if there is a pressure control ventilator with the volume guarantee, that is PRVC mode, that is pressure control volume regulated mode, if it is there, that mode is preferred. And with that, we can keep the airway pressure less than 30 centimeter of water. And how much tidal volume is the, we have to keep is a 6 to 8 ml per kg with the ideal body weight. And we have to adjust the respirator to maintain the normocapnia. TTCO2 is must in this way. And how much FiO2? It's not percent oxygen. As much as less possible, the FiO2 should be given around 0.7, 0.6 is preferred one, and the SpO2 just above 90% is sufficient for us, because it is for the prevention of the atelectasis. If you ventilate with the 100% oxygen, and if there is airway small airway collapses, all the oxygen inside the airways get absorbed, and the airway, there is the atelectasis. And to prevent this atelectasis, the low FiO2 and keeping the PEEP 10, 12 centimeter of water should be given. And to open up the collapse alveoli, we have to recruit the lungs intermittently with the high tidal volume and high pressure for a short period of time. And at the end of surgery, patient during extubation, patient should be well awake and should be free from the reversal. If at all, you can take the help of train of 4 your monitoring gadgets, and relatively pain-free. And while extubating these patients, we have to keep the suction catheter inside the oral cavity and not inside the tube, because if you, many I have seen, they put the suction inside the tube and they take out the tube. So that will cause more atelectasis, that sucking of the air from the lungs, and they tend to, small alveoli tend to collapse more. And we feel that this patient is super obese and their extubation might be difficult, so you can extubate over the this airway catheter. So this is a long hollow catheter is there, so you can put that and then take out the tube over it, and keeping this catheter inside there for some period of time. So whenever needed, you can reintubate again, or you can insufflate this catheter with the oxygen. And if patient, suppose cardiac patient is there and don't want to be patient completely awake, but airway you feel it's somewhat difficult, so it is a Bailey's maneuver. You put the LMA behind the endotracheal tube, then inflate the curve of the LMA, deflate the curve of the endotracheal tube, and take out the endotracheal tube and connect with the LMA. So this can be done. Patient is having a cardiac issue and you don't want to be hemodynamically compromised during the extubation if patient becomes awake. So post-operative also, we have to continue immediately the high flow next oxygen, or we have to keep the API valve on 10 or 12, continue the monitoring while shifting to the ICU, and we have to manage the analgesia mainly with the regional anesthesia, or if at all IV with the opioid-free analgesia to prevent the postoperative sedation and airway collapse. Early ablation is must, and the chest physiotherapy, incentive spirometry, and nebulization is must in a postoperative period. So we need help of many departments to manage these obese patients very effectively. And thank you so much.